All right, so allotransplant, is there a role in myeloma? The answer, I can make it short, yes, there is. But who should be transplanted, I think, is the key question. And we heard so many things, so let me bring this in before that's something I needed to get out. All the presentations, frankly, I think it's really time that we differentiate risk and do risk stratification from the beginning and don't lump all the results into one curve, basically. And we learned, I think, that relapsed refractory, or that everything you heard, that once patients relapse after autologous transplant or after maintenance treatment multiple times or so, are a different category of patients. Relapsed refractory, you heard early on, is different, and I will talk a little bit about primary and secondary plasma cell leukemia. But what is really the issue with allogeneic transplant right now is, I think, comparable to the questions that we ask about autologous transplants. That is, who, when, how, and maintenance, yes or no. I think we should address the same questions regarding allogeneic transplant. Who should be transplanted? When should we do it? How can we do it? And is there any role of maintenance treatment after the allogeneic transplant? We heard a lot, and let me just say this as gene expression profiling. We heard already that a high-risk disease, basically, despite of the fact, that's the right pointer. Is there another one? I don't think this is working. Hold on a second.
It's out of juice.
Yeah, out of juice? Okay.
Yeah.
All right, so let me try without then. I think this just ran out. But on the left, you see by gene expression profiling over the years a significant improvement in outcome of patients with intermediate or low-risk disease. On the right, you see this does not really apply, despite of the fact that there were novel agents introduced. So I think high-risk disease, we heard a little bit about it, needs to be defined from the beginning, and high-risk disease should also define the treatment approach from the beginning, as far as I see it. And we heard about deletion 17p in 10% of newly diagnosed patients. We heard about T414, 1416, deletion 13q. We know that haplodiploidy is a risk factor. We heard early relapse after autologous transplants certainly puts the patient into a different category. And we heard a little bit of the revised ISS staging. Therefore, all in all, I believe high-risk disease affects outcome and should therefore also affect treatment. Not to repeat all of this, but I think this was a brilliant idea, and I'm not sure, Antonio, was you the one who defined the revised ISS staging? Brilliant idea. This is what you see, outcome to lump the ISS stage with high-risk cytogenetics and LDH. But remember, these outcomes or these curves are on newly diagnosed patients. That curve will look different if we applied it to relapsed patient category in terms of progression-free survival. But I can't wait to see this applied in that setting, for example. So who should be transplanted? When and how, and what is the maintenance? So I developed at Memorial Sloan Kettering Cancer Center a totally different transplant program for patients with multiple myeloma, because it was time to really get a little bit more aggressive and not fool around much longer with the non-myeloablative transplants. We know from past history that the conventional allotransplants for multiple myeloma did not really work that well because the transplant-related mortality was unacceptably high. 53% in this study from Bart Barlogy at Arkansas at the time showed within day 100 post-transplant, patients died within this time period in this randomized trial. Other trials later on, the non-myeloablative transplants showed reduced transplant-related mortality, but unacceptably high. You see the 10% to 15% here, or 16%, but unacceptably high rates of acute and chronic graft-versus-host disease. Therefore, we needed brisk changes, and to no surprise, the allogeneic approach for patients was kind of inhibited. So at our place, we then, since we were experienced with T-cell depleted, or now we call it C34 Selected Allotransplant, we changed the whole paradigm by saying, what can we do in order to reduce acute and chronic graft-versus-host disease, number one, and if we can do that and reduce mortality associated with that, would that allow us to apply allogeneic transplants to a broader category of patients that are at risk to not have a durable progression-free survival anymore? And you see in the eligibility criteria here that we primarily focused on relapsed multiple myeloma following autotransplant. They had high-risk cytogenetics in addition to the relapse, or they had a relapse within 15 months post-autotransplant. The only requirement in the beginning, I left this really wide open, was that patients received at least a PR to salvage treatment, which could have been sometimes because they were resistant to bortezomib and other drugs, a second salvage autotransplant with melphalan. Our conditioning regimen is busulfan, melphalan, and busulfan, melphalan, and fludarabine. ATG is needed to prevent graft rejection, and the transplant was performed with the Clinimex device, which leads to a C34 selection of the cells by magnetic beads, and all the other cells that within the collected cell preparation are just flowing by the magnetic bead, and within this population we'll find the T cells that are finally depleted. In the end product of this C34 selected product, we don't have more than 1 × 10⁴ per kilogram of T cells. That's the key number. 1 × 10⁴ is all we have at the end. And here's the whole paradigm. We'll conditioning the patients with busulfan, melphalan, fludarabine as shown, and at the doses on the right. And then in addition, we built in maintenance treatment, which is not a drug treatment. We built in immunotherapeutic approaches. In the beginning, we focused on administering Donorlymphocyte infusions at very low doses. You can see 5 × 10⁵ T cells per kilogram at the earliest time point, 5 months post-transplant, given in 1 dose. 3 months later, another dose. 3 months after that, another dose at 1 million per kilogram. This is, and this published, you can read it, just came out like 4 weeks ago in BBMT, the report of 44 patients with multiply relapsed disease and high-risk cytogenetics. The key message here is in the middle. You can see that all these patients had 6 to 10 lines of treatment, which means they had about 7 to 10 relapses prior to the allogeneic transplant. You can also see in bold that the majority of these patients really required a second autologous salvage transplantation to at least achieve a partial remission. So this is about the most aggressive and most toughest patient population that you can transplant with an allogeneic transplant in the beginning. But the key message is this, and that was basically really the major question in the beginning: can we reduce graft-versus-host disease? And you can see here in these 44 patients that now have a progression follow-up of more than 3 years, the graft-versus-host disease acute, grade 2 to 4, is only 2%. That's key. Transplant-related mortality in this cohort is 18%, which is a little bit higher than we usually see with T-cell depleted transplants. Unfortunately, within these patients, we had 2 patients that got infected with Tamiflu-resistant flu at the time and never recovered from this. One patient, Wall Street, who didn't want to listen to me, he flew to London 6 weeks after transplant and came back with acute toxoplasmosis. So that was really out of control for everybody to treat these patients or control these patients. But most importantly, chronic graft-versus-host disease, 0%. In these 44 patients, and I can add to this, in over 100 patients transplanted, the chronic graft-versus-host disease maintained to be 0%. Outcome is promising. Again, if you remember what the readout of these patients was, this is a median follow-up of these 44 patients of 25 months, ranging from 11 to 82 months, and the overall survival at 4 years is 42%, with an 18% of progression-free survival. What we learned, though, is when we analyzed these subcategories a little more, that the amount of chemotherapy given prior to the allotransplant is key. You can see here, for example, divided by 3 to 4 lines, 5 to 6, or more than 6 lines, that the progression-free survival in those that are receiving less than 6 lines of treatment at 2 years is 42%, and still 25% at 4 years, and equivalently the overall survival. We also looked at the outcome based on disease status prior to transplant. If we could get patients into a VGPR, they do significantly better in overall survival at 4 years, 62% versus 19% that only achieved a partial remission. We also found out then, and this came basically really during the analysis of these 44 patients, that we had 13 patients within this cohort that had extramedullary disease. And that wasn't really because we didn't really have any restrictions whatsoever at the beginning of the trial. But when we looked at the presence or absence of extramedullary disease, you can see that the presence of extramedullary disease has really a dismal outcome, and so is the progression-free survival, which is consistent with everything we heard in the morning. So now this is, I think, is the key population to compare to all the chemotherapy regimens that we heard in the morning for refractory or multiply relapsed disease. These are patients that within the 14 that did not have extramedullary disease, that achieved a VGPR despite of their 4 lines of treatment or multiple relapses and had less than 6 lines of treatment. Their overall progression-free survival at 48 months is still 53%. At 2 years, you can see it's 75%. At 4 years, it's 53%, with an overall survival of 100%. That was the platform now to say this is potentially something we should integrate into the overall risk stratification for patients with high-risk disease. And I think what we should learn is don't wait until you really exhausted all the options. You should do the allogeneic transplant at least at 2nd or 3rd relapse, and don't wait until you really brought them through all the drugs that are available. But more importantly, T-cell depleted transplant as we apply now does not require immunosuppressive therapy. And for that, which is the second part of my hobby at Memorial Sloan Kettering, we integrated adoptive cell therapy, which comes in different flavors. And as I showed in the beginning, we just started with simple donor lymphocyte infusions. And when we administer donor lymphocyte infusion, as shown in this single patient here, who was only 39 years at time of diagnosis, had a high-risk cytogenetics, relapsed 3 months after autologous transplant. He got the allotransplant. His M-spike was still persistent after the transplant. He got 1 dose of donor lymphocyte infusions, and over time, he went into complete remission. And we gave a consolidative dose of donor lymphocyte infusions, and this patient remained in complete remission for more than 6 years. In fact, 7 years in total. But what happened during these analyses, when we asked the question, what do we do with donor lymphocytes, we found out, and that was derived from other clinical trials that I had, that this patient developed a striking amount of WILM's tumor antigen-specific T-cell responses following the administration of donor lymphocytes, as you can see on the left upper panel, which is done by Tetramer analyses. You can see a T-cell frequency of more than 3% of those that are specific for WILM's tumor antigen. Now, that then asks, the WILM's tumor antigen is very well known and described in the immunotherapy community. This is, if you see the upper bar, that is the most sought after, basically antigen for adoptive cell therapy. What you don't see here is that all the cancers and tumors under the sun have been evaluated for WT1, except for multiple myeloma. So we didn't know that much, but the WILM's tumor antigen is the zinc finger transcription factor, which has been described as an oncogene and has been expressed on AML cells, MDS and CML cells, but not much was known about the expression of these antigens on multiple myeloma cells. Therefore, we then asked the question, if donor lymphocytes induce a WT1 specific T-cell response, could this potentially be a target for adoptive cell therapy post-transplant? And we went into immunohistochemistry analyses and found an antibody that stains the kidney, which is by nature expressing WT1, and then stained myeloma cells in bone marrow with CD31, and then expressed and then stained these are the same CD138 positive cells with WT1 and could show the faithful co-expression of WT1 on the malignant plasma cells, whereas it's not expressed on the benign plasma cells. You can see here that this correlates, You can see here that this correlates nicely with with the expression by immunohistochemistry. So the more plasma cells you have, the more the WT1 is expressed. You can see 4+, 3+, 2+. That is the grading of the WILM tumor antigen expression, which nicely correlates with the original reports of the pathologist who signed out the original pathology by immunohistochemistry, shown here. The next thing, and this is, I think, the coolest thing you will hear today, because we then developed a monoclonal antibody, which is a T-cell receptor-like monoclonal antibody that has the capacity to bind to a peptide derived from WT1 in the context of HLA, in this case of HLA-A0201. The T-cell receptor-like antibody here only recognizes peptide, the peptide derived, which is called RMF peptide from WT1 in the context of HLA-A0201. If you have HLA-A0201 with a different peptide, it doesn't bind. If you have the appropriate peptide with a different HLA, it does not bind. It's very specific and sensitive for RMF plus HLA-A0201. And here's the description of this antibody. What we could do with this, if we used bone marrow from HLA-A0201 individuals and HLA-A201 negative individuals, there's no staining whatsoever. If we take a patient with plasma cell leukemia and do a dual staining for CD138 and the antibody, which is called ESK, you will see that all the plasma cells in the blood, in this case, are also bind to the monoclonal antibody. In other words, all the plasma cells express this particular peptide derived from WT1. This is the control antibody. And if you use another one with plasma cell leukemia, you'll see the same results. But if you have a patient that is HLA-A0201 negative, but has still plasma cell leukemia, you see the staining for the plasma cells, but you don't see the staining for ASK, for this monoclonal antibody. That's really important, because here you see, in this case, I went then back to several patients that I had. This is a patient that has plasma cell leukemia and is HLA-A201 positive, but is in complete remission. And what you see, that number one, you don't see any immunohistochemistry positive for WT1. You don't see any binding of the ESK1 antibody, confirming the complete remission. This is a patient with lots of disease that is, as you can see here, staining significantly by immunohistochemistry with WT1. But since he is HLA-A0201 negative, the antibody does not show any positivity. And the positive control, obviously, is the patient who has disease and who does express HLA-A0201. You can see here that the immunohistochemistry is positive, and so is the staining with the monoclonal antibody. So what this says then, at this point, WT1 expressed in plasma cells, it is expressed on the surface, the peptide is specifically presented. If that's true, then all you need to do is do the transplant, generate WT1 specific T cells from the donor, infuse the cells, and see what happens. And we did this. We wrote a new clinical trial targeting and focusing on patients with relapsed refractory disease or plasma cell leukemia. The platform is exactly the same as I showed before, T-cell depleted transplant, but the cells that we generated, then the WT1 specific T cells, can be administered at an early time point post-transplantation, because over the time of the culturing process, they lose all their alloreactivity and become significantly specific for WT1. I'll skip this part because it's very complicated, but the way we do this is we use overlapping pentadecapeptides of the whole protein, break them down in 15 mers, have a pool of peptides, load them on antigen-specific on antigen-presenting cells, and generate T cells that we can infuse. Just to remind you that the patients with secondary plasma cell leukemia have a really limited overall progression-free survival. In fact, this is overall survival of only 11 weeks post-treatment of standard of care, secondary and primary plasma cell leukemia here. This is at the end of the generation of this patient, which was 61 years old with secondary plasma cell leukemia, the cell product that we had. What this shows is that it's by FDA the requirement to show specific toxicity of targets that express WT1, and you see the lack of expression of alloreactivity. Therefore, these cells should not be able to induce graft versus host disease. When we analyze these cells, we can find out that these cells in this particular case are HLA-1101 restricted and can define the peptide that is being targeted by these cells. And here's the patient that then underwent the allotransplant. This was in 2012, in February 2012, T-cell depleted transplant that got 3 doses of WT1 specific T-cells in the beginning. And what we found out that there is a significant frequency of CD8 and CD4 positive T-cells in the blood of the patient after the infusion. And here you can see the outcome clinically. She still had she had a really significant disease load before the transplant. She still had disease load after the transplant. You can see the M spike was still at 0.8 at this point, and then she got the T cells. The M spike came down. She got another 3 doses of the WT1 specific T cells. She went in complete remission that lasted for 2.5 years. Then she relapsed. I started her on low doses of Revlimid that induced another immune response, and she has been alive for more than 4 years. Another patient, this is her bone marrow before, this is her bone marrow after the infusion. Last patient, here the same primary plasma cell leukemia. You can see the same effect. The WT1 specific T cells went in. The patient developed a complete remission, also shown by a negativity of cytogenetics, which were very high of P53 and high risk before. So what I'm trying to say is that maybe we should consider similar approaches for patients at high risk of relapse or already relapsed, as we do in the autologous setting. We have salvage treatment options, which could be VDT-PACE or second autologous transplant. We'll do the T-cell depleted transplant. We come up with immunotherapy thereafter, which could be Donorlymphocyte infusion or antigen-specific cytotoxic T cells. In fact, I can't really wait to explore if elotuzumab really does what it's supposed to be doing, that is activating NK cells. Then you know that the first cells that come back after allotransplant within 20 days are natural killer cells, to explore this option as a post-transplantation strategy. I think that was really what I wanted to say. So we have this approach now, C34 selected allografts, a platform for adaptive cell therapy. I also showed you that we do not need graft-versus-host disease to prevent relapse. So why should we induce graft-versus-host disease in this patient setting? And I showed you that WT1 specific WT1 antigen is a potential target for post-transplantation strategies. Thank you very much.